Good morning, good afternoon, or good evening. It's a real pleasure to welcome all of you for this first session of RIS Journal Club 2022. And we are very happy to see that there is a real interest around this first session of this new educational online event. So first, I would like to introduce a group of surgeons who practice and are interested in wrist surgery. And we wanted to organize this new online brainstorming event. So we asked some colleagues from all over the world to join WJC. And now 19 surgeons are involved in the project. So the principle is 1 question, 4 papers, and 1 debate format. And RIS Journal Club is exclusively dedicated to wrist cervical pathology, and all generations are involved. For each session, we invite a younger surgeon, a resident, to join the debate. So we also invite 1 or 2 guest experts to join the session and to help us in the final discussion. And for today, it's a real pleasure to welcome Jeffrey Yao from Stanford. Hello, Jeffrey. Hope everything is fine for you. Thank you so much for joining the session. How are you doing?
Doing very well. Thank you so much for having me. I'm very excited.
Thank you. For today, we have Margaret Ariani from Indonesia. She will moderate the session. Hello, Maggie. Could you introduce yourself, please?
Hi, everyone. I'm Margaret from Indonesia, and I will be your moderator for today, together with Jean-Baptiste.
Thank you, Maggie.
Hi, thank you.
For speaker panel, we have Ali Kavit from Turkey today. Hello, Ali. Could you introduce yourself, please?
Hello, everybody. Good evening, good afternoon. I'm Dr. Ali Kavit from Istanbul, Turkey. I'm working as a hand surgeon here.
Thank you, Ali. We have Ali Okhofatbour from Iran. Hello, Ali. Could you introduce yourself, please?
Hello, everybody. I'm Ali Okhovat from Tehran. I'm a hand surgeon working at Tehran, and I want to speak about proximal hamate autograft for proximal scaphoid non-union.
Perfect. Thank you. Marco Passiatore. Ciao, Marco.
Hello, everybody. I'm Marco Passiatore. I come from Italy, where I work as an orthopedic surgeon and hand surgeon in Brescia, Italy.
Thank you. Shihab Taleb from France.
Hi, everyone. It's a great pleasure to be part of you. I'm a hand surgeon in France, and I will have a great pleasure to talk about this tremendous topic.
Thank you. And Binoy Sayujanadan from India. Hello, Binoy. Binoy is with us. So,
hello.
Hello, Binoy. How are you doing?
Yeah, I'm fine. I'm fine. Hello.
Thank you, everyone, for joining. Please don't forget that RIS Journal Club is all about debating. It's a brainstorming session. So please feel free to ask any question or put any suggestion about the subject. Today, Jean-Baptiste will oversee the chat. And I think, thank you everyone for joining. And I think we can start the first session today. We decided to talk about scaphoid non-union, but not only scaphoid non-union, but the specific situation when we have a destroyed scaphoid proximal pole in young patients. And the question we will try to answer is how to reconstruct. And we will see it is a long journey from the graft to the implant. So as an introduction, I would like to share with you this very short clinical case of young patients who had a surgery in another center 3 years ago, and fixation of proximal pole was performed by an undergrad screw by an open dorsal approach. And as you can see here, the proximal part of the screw is in the joint. And after the patient was addressed to our consultation, and the main complaints were the pain and the decreased grip strength. But as you can see here, the patient has had conserved an excellent range of motion. And the pre-op imaging showed a dizzy and some signs of avascular necrosis and fragmentation on proximal pole. But there is no real evidence of osteoarthritis on the radiocarpal joint. So in such a situation, when we have to manage a young patient with a high functional demand, and when we know that the proximal pole can be kept, there is one question. What is the best therapeutic option here? Because we know the problematics here are very specific. Proximal pole is not salvageable, and the traditional and salvage procedures are not optimal here. So we know also that we have to avoid long-term complications, such as secondary carpal instability and at the long-term radiocarpal osteoarthritis. So in our making decision, we have to consider two main points: the cartilage reconstruction, of course, in this situation, and the carpal stability and ligament reconstruction as well. So to answer this question, how to reconstruct proximal pole in a young patient, when we look at the literature, we find that some keywords or some keywords association are more specific. And for example, I found that scaphoid plus non-union plus proximal pole was the most specific. So after the research, we have many number of surgical procedures that are published and proposed in the literature, but four main treatment options appear to be more relevant and have to be discussed. The first one is the pre-vascularized femoral bone graft. We have also proximal hamate grafts. We have also the rib osteochondral graft. And finally, the APSI, the pyrocarbon implant, appear to be relevant and to be discussed in this situation. So for free vascularized bone graft, we have some interesting papers and studies published in the literature, especially from these authors, Higgins and Berger. And we'll see that the main concerns are about the side donor morbidity and the technical difficulties of the microsurgical suture and harvesting the graft and the harvesting of the grafts. So we will discuss this with Ali Kavit with this paper published in 2019. For proximal hamate graft, we have some interesting studies, but with a very few number of publications, and we have recent interesting biomechanical studies. The main concerns are the effect on carpal biomechanics after proximal hamate harvesting. And we will discuss this with Ali Ochofatbour with this paper published very recently in 2021. For rib osteochondral graft, the main concerns are the safety of the technique and the learning curve. And we will discuss this with Binoy with this paper published in 2013. And Binoy will talk about two other interesting papers as well. And finally, for the APSI, the main concerns are the indications in young age patients, of course, and on the carpal stability. We will discuss this with Marco with the critical review of this study published in 2012 by Grafts and colleagues. And finally, Shia Taleb will try, after this critical review of key papers, to answer some question about the level of evidence. And we will wonder if we can draw a treatment algorithm in this tricky situation of destroyed proximal pole in young patients. And of course, we will ask our guest expert, Jeffrey, to share his point of view about this problematic. And throughout this webinar, we will try to answer the question how to reconstruct proximal pole. But what if the main question and the most relevant question was how to avoid this disaster of proximal pole destroyed in young patients with high functional demand? So we added this very last and short section, the if-only paper, and Maggie will very quickly present this article sent and proposed by Professor Matula as a conclusion. So thank you everyone for reading papers. The debate is open, and I think we can start with Ali with pre-vascularized femoral bone graft. Thank you. Ali, you can start. Thank you.
Thank you, Alam. It's a pleasure to be a part of such a great organization.
Thank you.
And I'm sharing. Hello again, everybody. I'm Dr. Al from Istanbul, Turkey, and I'm going to talk about medial femoral trochlear osteochondral flap. Medial femoral trochlear flap is probably one of the most well-known and preferred technique for recalcitrant scaphoid nonunions. As known, the medial femoral trochlear is an osteochondral free flap harvested from a non-weight-bearing portion of the patellar femoral joint. The osteochondral segment is vascularized by the transverse branch of the descending geniculate artery. The technique was first described in 2008. Since then, this technique has been started to be performed for the reconstruction of scaphoid nonunions with destructed proximal pole and advanced stage of Kienberg disease. The paper I will present is from USA. Dr. Pett and Dr. Higgins reported their experience with medial femoral trochlear flap with at least 3-year follow-up. The study is published in Hand Clinic in 2019. The authors did not mention the time they started, but until January 2018, they performed medial femoral trochlear flap reconstruction for 41 scaphoid nonunion patients. 10 patients in whom complete postoperative clinical and radiological follow-up data were available were included in the study. The mean follow-up time was 4.1 years. And I would like to draw your attention to the mean age of the patients. It was 21.5 years, really young and high demand patients that which we have to reconstruct their proximal pole. Unfortunately, the salvage operations may fail to meet their high functional demands. All patients underwent medial femoral trochlear reconstruction for indication of proximal pole nonunion after an unsuccessful open reduction and internal fixation. The authors supported their outcomes under 3 parameters: clinical, radiological, and patient-reported outcomes. When we look at the clinical outcomes, we can see on the table the degrees of the wrist range of motions postoperatively. The authors didn't mention the preoperative values, but they compare these postoperative values with the uninjured contralateral side. And these parameters fall short of the normal contralateral side, and according to the authors, this amount of wrist motion is functional for most activities. And recipient side complication was observed in one patient. It was wound dehiscence, which was treated with debridement and secondary closure. As donor side complication, ongoing knee pain was observed in one patient, and this was also treated with arthroscopic debridement. For radiological outcomes, union was achieved in all 10 patients, which was demonstrated by computed tomography 3 months postoperatively. The authors measured the radial nape angle and carpal height ratio to evaluate the carpal alignment and carpal collapse. The radial nape angle of 7 patients with a mean of 4.1 years follow-up was minus 6.3 postoperatively. This is a near neutral posture and slightly better than the preoperative values. The carpal height ratio of these patients was 0.5 postoperatively, which is also slightly improved from the preoperative values. This value shows that there is no observed carpal collapse during the follow-up period. The authors attributed this normal carpal alignment into 2 reasons. In their surgical technique, they performed an oblique osteotomy to the scaphoid, which is parallel to the scaphoid facet of the radius. This allows the preservation of the distal most portion of the scapulomate interosseous ligament. And the second reason is overstuffing of the proximal pole resection cavity, which means shaping the flap slightly larger than the native proximal pole so that it fits tightly in the resection cavity. By this way, carpal stability maintained by the tension secondary stabilizers. Another parameter that authors look for the radiological outcome is arthritis. 1 patient showed evidence of progression of radioscopic arthritis. The radial nape angle of this patient was minus 29 degree postoperatively, which is worse than the preoperative values. However, interestingly, despite this radiological outcome of the patient DICE score was 0 3 years after surgery. The authors evaluated subjective outcomes with DASH score, DASH questionnaire, knee injury and osteoarthritis outcome score, and WOMAC score. The last two is for the evaluation of the donor site. When we look at the DASH questionnaire, the scores of the DASH scores improved significantly postoperatively of patients, and overall good functional outcomes were achieved according to the knee scoring systems. According to the knee injury and osteoarthritis outcome score, some donor site morbidity are related to sports and recreation, whereas the routine daily activities are less effective. There are few studies with small numbers of cases and short follow-up period about the medial femoral trochlear flap. The common points of all these studies are high union rates, improvement in wrist pain and functional subjective outcomes of the patients, improvement in grip strength, no carpal collapse, and no significant change in range of motion. High union rates were achieved because the flap provides two important conditions for union: biology and stability. The biology comes from it's a vascularized graft with good and persistent perfusion in the persistent area and good quality, has a good quality of cancellous bone. And also, flap can be harvested rather big, so we can firmly fix the flap graft to the distal scaphoid, so it promotes improves the stability. And also another advantage of the flap is less donor site morbidity was observed with this flap. The most common donor site morbidity is the knee discomfort, which is usually resolves 3 months after the surgery. The disadvantages of the technic are it's a technically demanding surgery, which requires microsurgical skills, of course, and also the wrong operation time and other disadvantage of this technique. As a conclusion, medial femoral trochlear flap leads to a good functional subjective outcomes with high union rates in the treatment of scaphoid non-use. Also, a proximal pole destruction can be replaced using a vascularized osteochondral flap with promising short and mid-term results, preventing carpal arthritis and collapse. And for a definitive conclusion, we have to wait for the longer follow-ups. Thank you for your attention.
Okay, thank you so much, Ali. So we go to the next speaker. Our next speaker is Ali Okhovat. He will be presenting reconstruction with proximal hamate graft. Ali O.
Yes, it's my pleasure to be with you now. Let me share screen. Okay, can I start?
Yes.
I'm Ali Okhovatpour, hand surgeon from Tehran. The paper which I want to present now is published in Journal of Hand Surgery and Hand Surgery and Rehabilitation in 2021 by Saruhan et al. From Turkey. It's an almost new technique for reconstruction of proximal polyscaphoid non-union with avascular necrosis by using proximal hamate, and it's 4 cases. As we know, scaphoid blood supply mainly is retrograded by dorsal scaphoid branch of radial artery, and Hassan first proposed proximal hamate reconstruction for proximal scaphoid non-union in 2016, and the present study reports result in 4 cases of reconstruction of proximal polyscaphoid non-union plus avian using proximal hamate autograft. Mean age of the patient was about 25 years, mean interval between injury and reconstruction was 7.5 years. In 3 patients, no treatment was given following the fracture, and in the other, internal fixation was performed preoperatively. Avian was diagnosed on wrist MRI in all patients preoperatively. Here is a demographic of the patients. As you see here, the dorsal incision was done like this, and ligament sparing dorsal capsulotomy here, as Berger described, done, and the joint was open, the scaphoid was assessed, and necrotic proximal fragment excised. Here is intraoperative photograph of the patients. The asterisk shows the proximal pole of the scaphoid, which is here, which is fragmented avascular, and here is hamate osteotomy line, and about 8 to 10 millimeter of the hamate with volar capitohamate ligaments was resected and put in the void of the scaphoid here and fixed in this case with 2T wire. For better visualization of the technique, I show the video of mine patients. Here you can see the fragments, which is avascular and here is the hamate with volar CH ligaments. It rotated 180 degrees and insert in the void of the scaphoid. You can see here the geometry of the scaphoid like as the hamate. So it's the photos of the mine patients. Let's back to the paper. Operative details here is one patient with 2T wire fixed and the other with carotid screw. Scapular stabilization were not done in 2 patients, and iliac bone graft was for 1 patient. The split were removed in 6 weeks in a scapholonate fixation. If a scapholonate fixation was done, wire were removed in 6 weeks, and in patients who proximal hamate fixed by 2T wire, the wire were removed at 8 weeks. Mean follow-up was 14 months. After the last control union was determined on CT scan, 3 patients reported subjective decrease in pain. Mean grip strength compared to unaffected site was 24%, and mean flexion extension was 55%. And radial ulnar deviation was 63 compared to unaffected site. Mean dash score was 32, and union was observed in all patients. Here is the results, as I mentioned previously. Intraoperative and postoperative radiograph and CT scan here, preoperative in these 4 patients, preoperative early post-op and 9 months after surgery. Here, preoperative early post-op 22 months, and you can see here the consolidation and the union. Here pre-op, early post-op, and 12 months. You can see here, I think it's a scapulary dissociation. And pre-op, early post-op, and 12 months post-op, and union was achieved here. So in discussion, advantages of this technique was graft harvesting from carpal region and no microvascular procedure, offering a structural osteocontrol because of morphologic similarity to proximal pole of the scaphoid and easier procedure than vascularized medial femoral trochlear free flap, and is safer than osteocontrol autograft reconstruction and vascularized MFT free flap due to lack of donor site morbidity. Here, no radiologic sign of longitudinal space widening, DC or SL dissociation means that suggests harvesting the proximal hamate is safe in terms of donor site morbidity. And at last control, 3 of 4 patients reported a satisfactory decrease in pain compared to preoperative period. So using proximal hamate as a graft led to no secondary instability, and Harley showed that arthroscopic proximal hamate resection of about 2.4 millimeter did not have any clinical or biomechanical influence on carpal kinematics. But what was the debates? As you know, scapular ligament reconstruction here does not do, and technically it's not always possible to relocate capitohamate ligaments. In this study, only 1 case had enough capitohamate to be used for SL ligament reconstruction, and in 1 case only SL key wire fixation was performed, and in 2 other cases neither ligament reconstruction nor SL key wire fixation were possible. But during follow-up, none of them showed any sign of carpal instability. Furthermore, scapular ligament reconstruction may not be really necessary, but no definitive conclusion because of shortness of follow-up period. So subject is open to debate. Weakness of this study was retrospective nature, limited number of patients, short-term follow-up, and inadequate preoperative recourse. However, it's the first case series on this technique in the literature. As conclusion and final, in these 4 cases, union was achieved and pain decreased. Objective functional results were moderate, no donor site morbidity at follow-up, and finally, they believe that proximal hamate reconstruction can be an alternative in proximal scaphoid non-union plus AVN. Thank you and hope to see you all after the pandemic.
Thank you, Ali. It's a very beautiful presentation. So we go to, oh no, we have a little time for question and answers. Perhaps I would like to invite Jean-Baptiste, my co-moderator. Do we have any questions from the audience?
Yes, we have a question from Richard Ambrose. Do you only resect the necrotitis proximal pole and insert hamate in its place? Or does it solve the issue of hypovascularity in this region if it's not a vascularized flap? Or do you resect scaphoid up to waist where the vascularity is better?
I think it's a question for Ali Ohofatbour, no?
Yes, and Jeffrey Yao answered the questions in answered, resect the pole until you identify bleeding at the remaining distal pole.
Maybe Jeffrey or Ali, you could answer.
Sure, I'd be happy to answer. Yes, this is a very nice technique. We can discuss it further in the discussion. I think that the benefits of this technique are in the same site. So one dorsal incision to the wrist, and you can harvest your graft and replace the proximal pole of scaphoid. To answer the specific question, you remove the proximal pole that's diseased and resect the remaining distal pole / waist until you identify healthy bleeding bone, which is usually not very much. Usually a millimeter or so of the distal pole needs to be removed to identify a healthy bleeding bone to provide the bed to attach either the hamate graft or the MFT or the rib graft to provide healing to the remaining distal pole.
So your advice is to overstuff the graft here, Jeffrey?
That's right. Jim Higgins showed in a nice biomechanical study that in order to stabilize the carpus and prevent instability, the goal is to overstuff the joint, particularly in the situation where there's no ligament to repair or reconstruct. And that's one potential downside of the hamate graft, is that the hamate is the size that it is, and there's no way to increase the size of that graft. And in Dr. Kakar's work, he showed that about 20% of the time that the proximal pole of the hamate is inappropriate or insufficient size to match the scaphoid, and certainly to overstuff the gap that has been created. And thus, he recommends, and I recommend, a CT scan prior to performing the hamate autograft procedure to ensure that your hamate's the correct size, because the last thing you want to do is go in there and identify your hamate is too small when you try to reconstruct that proximal pole.
Thank you, Jeffrey. Maybe Ali, you have something to add?
No, I think this is clear, and maybe, as I told before, a little shrinkage. I think about 10% shrinkage of the avascular fragment will happen, and the small fragment will be smaller.
Okay.
And we have a question from Christophe Matoulin. Don't you think that the benefits and the risks should be carefully measured before considering this type of procedure?
Thank you, Professor Matoulin, for this question. We will discuss, of course, this problematic, and we will debate just at the end of the webinar with Jeffrey and Chiab. So we will surely answer this question. Thank you. Maggie?
Okay, I think we should go on to the third presentation. We go to Binoy. Hello, Binoy. He will be presenting reconstruction using the rib autograft. So Binoy,
thank you. Yes. Good evening, everyone. So I'll be talking on the rib autograft. It's regards from all of you from Cochin, India. So this is the hospital which I work. So scaphoid fractures, we know that involves the proximal pole, often results in non-unions owing to the size of proximal fragment and its limited vascular supply. So we know that when there is a loss of radial strut by fracture or necrosis of the proximal pole, the scaphoid may produce substantial destabilization of this column. So we have solutions for this, like the use of a compression screw with or without bone graft, which is successful in most instances. And we do have several longitudinal studies which have highlighted the risk of post-traumatic degenerative changes in the presence of a non-union. So when there is a non-union, it always poses a risk to the stability. So, but we know that the treatment options are limited for those cases of persistent non-union and a deficient proximal pole, which are deemed to be unsuitable for conventional bone grafting technique. So we do have treatment options like vascularized bone grafting, but the question comes when there is a small proximal fragment. So we do have techniques like which was described, like excision of proximal pole and repair of the scapholonate ligament. But if the proximal pole is like big, then the traditional options are the replacement with a silicone tendon graft or cadaver scaphoid allograft or the salvage procedures. We know that vascularized bone grafting is time consuming, it is technically demanding and may not improve the rate of union in patients with non-union and avascular proximal fragment. And if it's small, as I mentioned earlier, it's excision and advancement of the ligament is an option. But when it's large, we need to replace it. So what we will replace it? The initial techniques were with the silicone graft, but we have had enough of silicone synovitis, which led to abandonment after 1984. Then we have the tendon interposition results, which actually predispose patients to carpal instability. Then we have the cadaver scaphoid allograft, which has concerns regarding disease transmission, host rejection, and integration. And the salvage techniques, we all know that it will produce a loss of movement, grip strength, and are typically reserved for patients with associated degenerative changes. So then we have the options we have are like the rib or graft arthroplasty. So we have 3 excellent articles on this. One is by Veitch and second by Santo, and and the third one by Jeffrey Yao. So the concept is that the osteochondral portion of the rib is used as an interposition graft in patients, provides structural support to the lateral column of carpus. It improves the grip strength and the functional activity while maintaining the range of movements. So it is best indicated for patients with an unsalvageable proximal pole, scaphoid non-union, owing to fragmentation or because the proximal pole is too avascular to reconstruct. So we should notice that all these patients are younger and higher demanding. So all the 3 studies have included patients who are aged between 20 and 30. So the pitfalls are that when you take the rib autograft, the patient can develop a pneumothorax, but none of the 3 articles, none of the authors had any complications like pneumothorax. So this is a theoretical, like it is a possibility only. So otherwise the pitfalls of these procedures are minimal. So it is contraindicated in patients with congenital or acute chest wall deformities, and in those who are unable or unwilling to participate in the postoperative rehabilitation protocol of the wrist. The surgical technique is like, as we know, it needs a general anesthesia. We first dissect the scaphoid, then the deficient proximal pole is excised, and we do osteotomy till we see the healthy bone. Then the chest wall incision is just inferior to the 7th or 8th rib at the level of costochondral junction. The periosteum is elevated. Beneath the rib, the pleura is reflected using a small cob elevator. The costochondral graft is harvested from the costochondral junction using a sagittal sew, which needs careful attention. The graft is then, like, we need to shapen the graft. Then we press fit into the void and stabilize it with 2 KVS. So most important, when I went, I don't have any personal experience with the technique, but when I went through the articles, what I realized was one of the most important thing in this technique must be that shaping the graft as the proximal pole, which you need patience and you need some skill to do that. So when it's sized correctly, the graft will simply fill the space left by removal of the proximal pole. And the radiograph should confirm appropriate carpal height and restitution of Gilliland's line without overstuffing. And which at Santo have not mentioned doing anything with the interosseous membrane. So Santo has mentioned that if you want, we can actually using a suture, we can secure it. But Yao has mentioned that scaphoid is attached with a absorbable suture such as fiber wire to the perichondrium of the autograft. And the wrist is, we move the wrist and see the stability of the construct and to see whether the proximal carpal row moves as a unit without evidence of instability of the graft. We give a thumb spica cast, which changed to a short thumb spica cast after 2 weeks. If there is a good evidence of healing, 8 weeks after surgery, the cavities are removed and hand therapy is given. CT we can use to confirm the adequate healing before hardware removal. So this is the article by Santo, which was published in 1998 of JHS British. So the indication was a deficient proximal pole and the failed surgery for proximal pole fractures. He excluded cases with the degenerative carpal changes. The study duration was 91 to 95. He had 22 patients. Mean age was 26 years. Mean time from injury to primary surgery was 6 years. And the mean time from primary surgery to osteochondral graft was 25 years. And the mean follow-up was 2 years. So they had excellent results. All patients except one returned to their pre-injury location with some modifications. And some patients, 3 patients, they had to do styloidectomy. Sorry, not styloidectomy. They had osteophytes or the dorsal aspect of the radius, which had to be shaved to improve the union. So at that time, when he opened, he has done a biopsy to see how well the graft is integrated. And like they have found that the biopsy demonstrated variable survival of surface and deeper chondrocytes with changes in the articulating surface, suggesting adaptive metaplasia of the chondral portion of the rib graft. There was no loss of carpal alignment in the patients in the study, despite the deficiency of scapholonate ligament. And the radial column stability is retained by preserving the triscaphoid joint and restoring the scaphoid length and height. Next comes the study, which was published in 2007. So the indication was almost the same. The only thing is study duration was 96 to 2002. They had 15 patients. Mean age was 26 years. Their mean follow-up was 5 years. So they also found a significant improvement in pain, activity, range of movements, grip strength, and function scores. So they have mentioned that because of the radiolucent chondral and small bone components of the graft, the exact time to radiological union was difficult to determine. So most of their patients, except one, went for the same pre-injury vocation with some modifications, and they had almost the same results like Santo. So the latest article on this comes from Professor Jeffrey Yao, which was published in 2013 JHS. So this Professor Yao had 3 patients. So one was 19, the other one was 27, and the third patient was 18 years. And the mean follow-up was 2 years to 8 years. They all had good range of movements and satisfactory grip strength and a good DAS score. So the conclusion, the scaphoid proximal pole fragmentation and non-unions following surgery pose a unique challenge. Retaining the radial column is an important for the kinematics. Rib autograft is an interesting option to consider. It needs further studies and long-term follow-up. Thank you.
Marco will be presenting reconstruction using APSI. Marco, s'il vous plaît.
Yes. Can you see the screen?
We haven't seen your presentation.
Yeah. Okay.
Now we see it.
Yeah. Okay.
Okay.
I present this article describing this technique, describing the technique of implant of the APSI prosthesis under arthroscopic control with a long-term follow-up in patient with young patient with highly demanding patients. So I work in Brescia. This is the hospital where I work, and this is the hand team. So what's the APSI? The APSI is an implant made of pyrocarbon, which is made to replace the proximal pole. It has an adaptive shape to replace the proximal pole in relationship with the variable geometry or the first row or the carpal motion. So the APSI is a candidate to be a salvage procedure, maybe before salvage procedures as PRC and four-corner fusion mid-carpal arthrodesis. And the ideal indication is to implant this kind of prosthesis with intact cartilage in the scaphoid fossa. So in stage 1 SNAC arthritis. So it is an ongoing question. We are talking about this question in literature for a long time. And the recent literature tells us that we need for a real adaptive system to prevent the increase of wrist arthritis after the options we have that are the proximal pole resection or tendon arthroplasty. So the APSI is an adaptive system because it has a very low coefficient of friction. It allows the smooth motion because of the 2 axes of the implant in the complexity of the first row cinematics. And because it is made of pyrocarbon, it has a very good elasticity, very similar to the bone. So let's come back to the article. The article tried to answer this question: does the APSI work in demanding young patients, and does it give good results? And so this is my question: does it prevent the progression of osteoarthritis? It is the particular thing of this article we are to describe. It's that is describing the effects of this kind of surgery in functionally demanding patients with a new surgical technique. So this video is from the article. We are seeing the union side, the proximal pole, the lunate, and the triquetrum. And so from radiocarpal view, with the blade, the other is cutting the scaphoid ligament, and then with the forceps, he's removing the proximal pole. Now we can see it from mid-carpal view. So proximal pole removal. And then we can try the right size of the implant. We are already talked about the overstuffing, the space. We have 3 sides. And this is the final implant. We can check the location of the implant through the mid-carpal scoping. So the others underline the importance of doing stylodectomy, because the styloid is always involved in from the early stage of wrist arthritis. So they underlined also the pitfalls. I think one of the most important pitfall is to avoid volar capsule injury in order to avoid volar displacement of the implant. And of course, the injury of cutaneous nerve and the injury of the extensor tendons are obviously important when we are doing this kind of surgery. And about the postoperative management, maybe because of the arthroscopically implanted prosthesis, we don't have very important the need to immobilize the patient. So they suggest to use the splint that could be removed at patient's choice. So they describe the case history of 14 males with an average follow-up of 8.7 years, and they tried to implant this kind of prosthesis into patients who had waist non-union of the scaphoid. The case history includes patients with more than stage 1 arthritis, and these are the results. They observed improvement in pain, in range of motion, and grip strength. About the patient-related outcomes, they obtained very good results, but they had some clinical failure. For example, in the waist non-union cases. In fact, in this patient, they were forced to convert in further surgery for corneal fusion, so in a salvage procedure. And they observed one case of early volar subluxation that required the repositioning of the implant and stylodectomy, and 3 more patients required stylodectomy as further surgery. About the radiographic outcomes at last follow-up, they observed all stable implants, 6 cases of capitate notching, but I don't know if it is significant or not, maybe not, and dizzy correction in 5 cases out of 6. In conclusion, we can say, according to the result of this article, that this technique can be good for to treat this kind of disease in young patients of less than 65 years old. Maybe is not appropriate in waist non-unions. Maybe it should be performed stylodectomy. And the implant is highly biocompatible in terms of material and heavily stable. But it is a retrospective analysis that describes an innovative practice that requires a little bit of experience. Of course, a comparison group was not described. And this is my concern about the arthritis evolution. They included patients with more than SNEC 1, but they had good results. So it is significant to take care about their wrist arthritis stage or not. So I finished, and thank you.
Thank you, Marco. Jean-Baptiste, do we have more questions?
Yes, we have a question from Christophe Matulin. We know our 20 years of follow-up on the APSI prosthesis, which under arthroscopy is a very simple technique with reliable result. Do you think that the rib graft is a sufficient advantage and justifies the complexity of the rib technique? I think it's a question for Jeffrey Yao and all the participants.
So anyone willing to answer?
Jeffrey already answered on the chat, but please, Jeffrey, can you just repeat, tell your point of view about this, please?
Absolutely, yes. I think the APSI is a very attractive option. It's very, you can't argue with those results, and the very beautiful technique as shown on the video. Unfortunately, in the United States, the APSI is not available. It's not FDA approved, to my knowledge, so we don't have that option available to us. And so as a result, my favorite technique is the rib autograft in this situation. I think the morbidity is much less than the MFT. I think people, as hand surgeons, orthopedic surgeons, we're not very comfortable operating around the chest wall and the thorax, and that's understandable. That's not our training, but our plastic surgery colleagues have been doing this for a long time for mandible reconstruction and nasal reconstruction and other reconstruction. And it's actually a very simple technique. The rib is very subcutaneous. It's a small incision over the rib cage. And as was elegantly described in the lecture, as long as you remove the pleura from the posterior aspect of the rib carefully, it's a very easy approach, and the harvest is very easy. If a pneumothorax occurs, which can happen, it's also a very simple solution. We insert a catheter, positive pressure ventilation by the anesthesiologist, sew up the wound in the pleura, and that's it. And it's a very straightforward procedure. So that's my preferred technique.
So there is no need to ask a thoracic surgeon to come with you in the OR, Jeffrey, for this technique.
So I think if the first time you do this, it may be reasonable to do it with a thoracic surgeon available just in case. I did it with one of my plastic surgery colleagues, Rod Hentz, who demonstrated the technique for me and taught me the technique, and it's very simple. We have, over the course of the years, had encountered a pneumothorax once or twice, and again, very simple. Sew up the pleura with positive airway pressure, and it's a very simple solution.
And APSI is not available in the US. Is it the only reason why you do not, choose rib osteochondral graft?
I think biologic healing of native bone to native bone always is more attractive to me than any implant, and that goes for any joint. Again, can't argue with the outstanding results as been described. So I think if it was available, it would certainly be something I would try. I just wonder that over time, with other interpositions, we see with tendon and other things that there's carpal collapse as the capitate pushes down and pushes the scaphoid unilluminated away. That's always a concern, particularly for the younger patient. The articulation of pyrocarbon or metal onto cartilage, I think, is less ideal than having the patient's own cartilage articulating with cartilage. So, but I think if it was available here, it would certainly be something that I would try.
Okay, thank you. Even in very young patients.
It would be something to discuss with the patient, but I'm very comfortable with the rib graft. I don't think it's dangerous at all, and I've had outstanding results with it. And Dr. Sandow, who described the technique, has over 10-year follow-up with 90% survivorship over 10 years, which is pretty amazing.
Thank you. Something to discuss with the patient. Thank you, Jeffrey.
Yes.
Other
Okay.
questions?
Do we have more questions?
No, we haven't.
Okay, so I would like to invite Monsieur Shihab Talib. Shihab, are you there?
Yeah.
Sorry, Maggie, I just want to ask a question to Ali Kavi. What do you think? Hello, Ali. What do you think about the technical difficulties of the graft from medial trochlea?
Yeah, actually, everybody can say it's the most difficult part of the surgery is the harvested graft. But if you are familiar with microsurgery, actually it's not so difficult to harvest the graft. In my experience, the most difficult part of the surgical technique is the shaping the grafts for the proximal pole, because you take a rectangular shape of graft and you have to shape it similar to the unique geometry of the proximal pole, and it's not as easy as it seems. The most difficult part for me, shaping and positioning the graft to the proximal pole.
Okay, thank you, Ali.
Thank you.
Ali,
Okay.
I have a question for you.
Yeah.
Is it common to have some anatomical variants in the pedicle?
Yeah, we can see some variations, like 10% of the patients, this descending geniculate artery can be absent. Then we can use the supermedial geniculate artery, or sometimes metaphyseal arteries going through the bone, over the bone. We can use these arteries. Yes, there are some variations.
So in your experience, you can have every time some artery to take to harvest the graft.
Sorry, I don't understand the question.
In any case, according to your experience, you have in any time found some artery to take to harvest the graft.
No, actually, we also face the variation once in our cases, and the descending geniculate artery is absent, but we use this supermedial geniculate artery for the pedicle. But it's pedicle a little bit shorter than the descending geniculate artery, but it's not a problem on the wrist because not too far.
Yes, of course.
Yes. Thank you.
Okay, so do we have any more questions? Somebody would like to add something more? Otherwise, we go to Shihab. Let's hear what he has to say.
Okay, so it's a lecture which tried maybe to sum up some kind of ideas we've talked about in the lecture of my colleagues. So first things is to know that the main goal of this surgery is the pain relief. And the second one is try to make this joint last as long as possible. I mean the cartilage spare. So before choosing the surgery, we have to choose the good patient. And as we saw in the different series we had discussed before, the age of the patient, it's the key point of those kind of surgery. Indeed, in the last one, patient were around 60-year-old or a little bit less. And in the others, it was around 20, 25, or 30. We need to wonder if the work of the patient would fit with the surgery we can advise him. I'm thinking, for instance, about the vascularized graft, using some things around the knee. Maybe it can be painful for the patient. And third is, what about the smoking fact that people maybe can avoid to tell you, and you're so eager to make a microsurgical procedure that can fail because of this. Second aspect dealing with the patient is the pain. Is it painful, or do we see only a non-union which is not painful in the patient, and just wondering what we can do? Second, how about the motion? I don't know if you saw in the last lecture, but the motion didn't be improved in each cases of different procedure. It means that the goal, as I told you, is not to improve the motion. I'm not sure we are able to improve the motion thanks to all those surgeries. And third is the grip strength. So we have to discuss with the patient in order to be sure what the patient is looking for. Thanks to surgery, we can advise him. And then we can explore the scaphoid. Why? Before choosing the surgery, we have to be sure that we have a non-union with no possibility of bone healing. So maybe we can add another exam, I mean angiography or MRI. I think it's mandatory. And then we need to assess that the stage of the beginning of osteoarthritis is not too far that we have to choose another surgery. So once we've done with all these questions, we have two options. The first one is the bone can heal. So let's go to conservative surgeries. Second one is not good bone healing possible in the situation we have to face. So in this kind of procedure, we have to think about salvage surgeries. So when we talk about conservative, we saw with the MFT surgery, we use vascular bone graft. I just put the picture of Matulan procedure for the scaphoid reconstruction. Maybe it's not the good one, but in sometimes we can try to mix some surgeries. And I think in vascular bone graft, it can give some good options. So the pros is that we have an anatomical reconstruction, as it has been showed before, and we have a blood supply. I mean, when we have a proximal pole, the main problem is the blood supply. But the drawbacks is that it's technically demanding. I know that when we are trained to make it, it's not as complicated as expected, but we have to keep in mind that it's not a daily surgery we have to do. The donor side morbidity, we have to talk about this. I think it's a good question because the patient didn't expect that we have to harvest something far from the wrist to reconstruct a tiny piece of his wrist. So we have to be clear with him. And then we have to be clear with him to say to him that the motion of his wrist will be maybe the least part of the goals we have to succeed in this technique. I mean, the stiffness, it's a great part of all those surgeries. Then when we can't do this, we have the non-vascularized procedure. We saw the hamate, I mean the hemi-hamate procedures, and we have, of course, others. But we have the same pros, is the anatomical reconstruction. And I think it's easier and faster while we stay close to the wrist with the hamate. With the rib, I mean, I agree with Jeffrey, is not as demanding because it's under the skin, but we fear realm we don't know as a trainee surgeon. I mean, when we hand surgeon, we don't know where is the thorax, we don't know where is the chest, so it's a little bit tricky for us. So we have to keep in mind that there is a high risk of failure, of course, as you can imagine. It's a donor site morbidity, as you can guess, in the chest. And of course, the stiffness of the wrist because you have a procedure that needs to open widely the wrist. So I think I had another question. I think it's interesting to ask this question because we have different type of fixation of this bone fragment. I mean, the proximal pole. We have the screws, and we use it for the fracture. We have to keep in mind that it can collapse the non-union surgical procedure because we don't have the same bone. In the fracture, scaphoid fracture, we need to have some compression. So the Herbert screws and all compressive screws are useful. But in the procedure of non-union, it can be harmful. So we have to be really concerned about this aspect. Second, in the key wires, I think it's easy, but we need to remove them. And it can treat some ligament problems. And the third, I think it's more tricky and less used, is the plates. We have more and more plates dedicated for scaphoid. I think maybe it's not a good situation for the proximal pole. And then when we can't use conservative procedures, I mean, we have the salvage procedures. I think it's not demanding procedures because we know that we won't repair wrist. We just try to avoid that the damage go far than only small pains. But we don't have the same wrist anatomy, and maybe we need to go to other surgery. Even though we think that it's a salvage procedure, we can go to wrist fusion at the end of all those treatment. So the first one, as we showed you, is the APSI. I think it's better when we use it with wrist arthroscopy, because if we can put it with a small incision, let's do it. I mean, if we can avoid to open the capsule, the wrist capsule, it's always better. Of course, it's a little bit demanding because you need to play in different rooms in the wrist with a small instrument, but it's totally possible to make it, and in the safest way. Second one, it's all the kind of fusion of first row carpectomy. I mean, we have to keep in mind, because even though it's a young patient, it can give you good results. So you have to keep in mind. And there is another one, maybe we didn't have time to talk about, is the neurectomy. Of course, when you have a heavy worker and the guy is painful and he have sometimes a good wrist motion and he's around the 30s, just wondering if he can keep on working in heavy working field, maybe just neurectomy can help him to save some years of working, and around the 40s, thanks to other surgeries. So I hope that we have new perspective. For instance, like Igor Rossel, who showed us, is the 3D printing dedicated scaphoid prosthesis, or some biological aspect in order to boost the blood supply in the this particular case of non-union. But nowadays we just have to keep this home to this message to our homes. I mean, we need to find the good candidate, the good patient that understand what we propose him, the good procedure. And what I mean by this way is the procedure we are trained for, we can manage properly, safely, and that give us the good results and the good surgeon. I mean, we don't need to, we have to keep in mind that the best question we have to ask to ourselves is, what would I do for my wrist? And with this question, we maybe find a good procedure. So thank you for this time shared together, and I hope we'll have a really good discussion around this topic.
Thank you, Shiab. Maggie, are you with us?
Yes. Okay, so after Shihab, I think we have Dr. Jeffrey Yao. We go to Dr. Jeffrey Yao now.
So Jeffrey, if you can just, we saw that we have many conservative procedures. Some of them are technically demanding. The medial trochlea graft, for example, with harvesting. We have some other procedures. The rib osteochondral graft, some of us are not very don't feel comfortable with this technique. Could you please share your opinion about how to manage destroyed proximal pole in young patients with high functional demand? The case I presented in the first place, please.
Yes, absolutely. First of all, I want to commend all of the presenters for outstanding lectures, really getting to the core of each individual procedure and all of these different options of treating this very challenging problem. And it really framed the problem very nicely. And basically the way I encapsulate it, sort of, I spoke already about it. For the most part, I do favor the rib autograft. Again, I would encourage you, if you haven't tried it, to try it. It's not difficult. I know it may sound scary to operate around the thorax, but it's very easy. Our plastic surgery colleagues have been doing this for decades with excellent success. And so I would highly recommend getting at least exposed to this technique and not just thinking, oh, it's too dangerous and I don't want to do that. I highly would recommend that. That being said, in certain situations, the other techniques are attractive. Obviously, we talked about the APSI. I think that's very attractive, particularly because it has very long-term results. And that is, in my opinion, the most important evidence for anything is long-term outcomes, right? For our younger patients, yes, the hamate may be fine, the MFT may be fine, but we only have, a few-year follow-up. But the longer-term follow-up with the rib autograft and APSI are difficult to argue against. And so I think that's the highest level of evidence. Unfortunately, like I said, in the United States, we don't have the APSI available, so that eliminates that possibility for us. And that's why I use the hamate graft. I mean, the proximal, the rib autograft. The hamate graft is attractive because it's in the same field as we talked about. So the donor site morbidity is less, particularly if you're scared about operating by the knee or operating in the chest. But again, we don't have long-term follow-up. We don't know what's going to happen with that mid-carpal joint. There is some thought that perhaps by removing the proximal hole of the hamate, it eliminates the extension force on the triquetrum, and so that may actually stabilize the DZ deformity. It may reduce the DZ deformity. However, none of that has been definitively shown. We do have cadaveric studies, but as you know, cadaveric studies don't always mimic what happens in the clinical patients. And so we don't know 5, 10, 15, 20 years down the road if that 18 or 20-year-old patient, what's going to happen if their mid-carpus is a problem, then that could be a major problem for that patient. So it is attractive, but I am a little bit cautious about that. Also, as I spoke about, the hamate morphology is not always matches the proximal pole scaphoid morphology, and so that could be an issue as well. Regarding the MFT, again, difficult to argue against the good results presented by Berger and Higgins and others, but it is a big procedure. It does take longer. In our institution, we do this procedure, but we usually use 2 teams, and so that the manpower is more. And I think the most important thing to point out with all of these techniques is that with any of these techniques, the chance of restoring the scaphoid back to its perfect normal morphology is very difficult. You saw some of those images from all 3 options, and you see the scaphoid doesn't quite look normal. But as long as you stabilize the proximal row, that eliminates or reduces the risk of developing post-traumatic arthritis. And that's ultimately what we're trying to avoid. In fact, we're just in the final stages of a manuscript where we're looking at scaphoid malunion and the incidence of scaphoid malunion going on to developing or needing a salvage procedure. And you can ask yourself, how many times have you done a PRC or 4-corner fusion for scaphoid malunion? We do it all the time for scaphoid non-union, but very rarely for scaphoid malunion. So the point is that as long as there is some connection, whether it be the hamate, the metatrochlea, the rib, to stabilize that scaphoid, the risk of developing post-traumatic arthritis requiring a salvage procedure is reduced. And so I think all of the options are certainly reasonable. It ultimately depends on your particular comfort level with each of the different techniques. I do think that in certain patient populations, for example, I had a soccer player who had it. He did not want me to manipulate his knee at all because that was his, that was very important for him for soccer. And so MFT was not an option. And so we did a hamate graft on that patient. But so there, as was pointed out in the last lecture, there's individual patient characteristics that may guide your treatment one way or the other. But as a general rule, I would encourage the group to consider the rib autograft. It's a very useful technique.
Thank you so much.
With no morbidity. I mean, the patient doesn't even know that piece of their rib is gone.
Thank you so much, Jeffrey, for this synthesis. Shiab, do you have anything to add, please, for this discussion?
I think Jeffrey said everything. He just summed up all the ideas and just maybe help us to spring into the chest of our patient to try the rib graft. I'm really eager to try it. We know close to my city in Besançon, we have a surgeon who uses it, Professor Aubert, and he used it, but not for the scaphoid, but for the distal radius reconstruction.
But Shiab, I think I think, if I'm not wrong, they published a series. Yes, for scaphoid. Yes.
Yeah, but I think I agree with you. When we have a young patient, maybe I will go to see Jeffrey for rib reconstruction if it was my wrist. Go to see Professor Matoulin if I wanted an APSI, and maybe to find James Higgins in Baltimore for a MFT. I'm really sure that each people can do the best things for the wrist of the patient, but
so the right indication for the right patient. But Shiab, in France we have the APSI. We indicate APSI because just as said in the chat, Professor Matoulin, we have it's a very simple and we have good long-term results, and it's not a problem in young age patients. We have to discuss with the patient that maybe we will have to change the implant after 20 years, for example. So that is what we do actually. But in the countries where the APSI is not available, I think we can ask our speakers today what they would do if it was their own wrist. No, yeah.
Can I just ask one question to Jeffrey? Because dealing with the motion of the wrist, I think we just focused on the pain, of course, and the grip strength. What about the wrist motion? I'm not sure we have technique that allows us to increase the wrist motion. We just try to save the scaphoid, but we don't care about the motion. What do you think about this?
I think that's a very astute statement. In fact, when I talk to my patients about this procedure, the goals of the procedure are, number one, to achieve union. Again, like I said, perfect morphology is not necessarily going to be possible, but as long as the bone unites, that's a primary goal. Number two is to prevent the development of post-traumatic arthritis from developing. If we are able to achieve those two things, I think the patient will do well. I don't promise the patient improved motion, but I think, and we showed in our study that the motion is certainly functional, but you're right, it's not likely with any of these techniques to return to normal. But the function, as we all know, that normal motion doesn't necessarily equate to normal function and vice versa. We don't need normal motion to have normal function. And so most patients have very good function as long as there's union and we prevent the onset of arthritis.
Great.
Thank you, Jeffrey. Just the question we wanted to ask with Shiab to all the speakers, if it was first Ali Kavid, do you have the APSI in your country? And
No.
if it was your own wrist, what would you choose after?
No, unfortunately, we don't have APSI in Turkey. And if my own wrist, if we have APSI, I probably choose it because it's closed operation. Not you have to open the joint. You don't destroy the vascularity. So probably I prefer it. But if I don't have APSI, my preferred technique would be MFT.
Yes, because you know. Thank
Yes,
you.
I know. And I want to ask Jeffrey a question. If you
Are you not a soccer player?
Yeah, I play, but just for fun. I have a question to you, Jeffrey. Ali, in his presentation, told about the shrinkage of the proximal hamate as non-viable. Do you have such an experience with rib grafts? Does it shrinkage or get smaller by time?
Yeah, I heard that. I wasn't quite sure what he was referring to because I haven't seen that with either of those graphs. Certainly not with the rib graft. I guess theoretically there can be a concern if there's loss of vascularity that to the cartilage that it could atrophy with time, but I have not seen that, at least in the patients that I've done.
Oh, thank you.
Vinay, please, do you have the APSI? What would be your preferred technique here if it was your own wrist?
If it is, if it is my own wrist, I hope it doesn't happen, first of all. So if it happens, I think I totally agree with Jeffrey Yao. Actually, I mean, so when you read the techniques, you feel that it's a little tricky to shape in the graft. But after listening to Professor Jeffrey, I'm so motivated to do one rib autograft. And I think maybe for my wrist, probably I will go for that. Maybe I'll fly to US and Stanford, probably.
So we are all going to coming to Stanford, Jeffrey.
You're all welcome.
Yeah.
Thank you. Thank you, Vinay. Ali O from Tehran. Do you have APSI? What would be your preferred technique, please?
No, we don't have APSI in our markets like as the others, but in my wrist, it's a little difficult question to answer because it depends on the work and depends on the stage of the osteoarthritis. I don't have any idea about APSI, but any avascular fragments, I think the results for any avascular fragments is not good. It's so-so. I don't know what about rib, but I think it's so-so because of the avascular nature and the long union time, maybe. I just want to have a question of Jeffrey. It's in my mind, but I don't know the answer. I think in every procedure, osteoarthritis and the stage of a snack wrist is important to choose the reconstructive procedure or salvage procedure. I think in very proximal scaphoid non-union, the snack wrist is progress a little different from normal waist non-union. And do you have any experience about the progression of the snack wrist in very proximal scaphoid non-union, and does it differ from waist scaphoid non-union or no?
I'm sorry, Ali. Let me see if I understand the question. So the progression of snack wrist with a proximal
osteoarthritis in very proximal scaphoid non-union is the same as waist scaphoid non-union, or it differ?
Oh, I think that's a great question. I do think that the rate of developing snack wrist in those patient populations is less than the waist, and that's because of the articulation with the scaphoid facet. And quite frankly, the radial styloid is less. And that actually brings up an older option, which hasn't been discussed, but is not rarely an option, is to excise the proximal pole of the scaphoid if it's non-united and advance the scapholunate ligament to the remaining scaphoid. Because that part of the scaphoid is not as critical. However, I do think that in the patients that we're discussing, the ones that are proximal pole, not just more of an avulsion of the scapholunate ligament, but a true proximal pole scaphoid that's fragmented and not salvageable, where there's a sizable enough space that can be filled with any of these grafts, I think that will go on reliably to develop snack wrist and the development of arthritis.
Thank you. I think we have to ask Marco. Marco, there is a question for you regarding the APSI. And first, I would like to ask you, what would be your preferred technique for your wrists, please? Yeah.
For my wrist, maybe the APSI, but I'm very interested in the rib graft. Maybe will improve my knowledge about this technique. I'm a little bit concerned about the donor side morbidity, not regarding the pneumothorax, but regarding the pain after surgery. But I think it is something we should learn how to do, and then I can establish if it can be available in my as a solution for my patient. But I think now in Italy, my preferred technique for my wrist could be the APSI in that case.
Thank you, Marco. Jean-Baptiste, there is a question for Marco for the APSI, I think.
Yes, the question is, how do you reduce the risk of dislocation with APSI? Do you have any tips?
About the risk of dislocation, of course, doing the procedure by under arthroscopy, you can reduce the approach without compromising the dorsal capsule. I think the APSI could be overstuffed, and but not a lot because of the shape of the implant, which is which adapts to the ulnar inclination and radial inclination. And another thing, I think it's very important to estimate before surgery is the continence of the volar capsule, because of the scaphoid non-union. The scaphoid tend to flex and to stress the volar capsule. So in that case, if you have an arthritis and a non-union which is going for a long time, you can have the incontinence of the volar capsule. So in that case, you can have the displacement of the implant. According to my experience, I think it's an important thing you shouldn't exclude. You should check before performing that kind of surgery.
Thank you. That is the advice. So thank you everyone for all these great suggestions and these presentations. I think we can just conclude the session with the if only paper with Maggie. Margaret, are you with us?
Can you hear me?
Yes.
Yes.
Okay.
How to avoid this disaster, please?
Yes, so this is just a very short presentation. So this is just an addition to what we have already discussed. We have talked about how to reconstruct, but maybe we should ask ourselves how to prevent destruction of the proximal pole, especially small proximal poles. Oops. Oh, sorry, wait. Okay, so sorry about that. I would like to refer everyone to this article. It's a book chapter written by Professor Matulang. It's about arthroscopic grafting and scapholunate pinning for scaphoid proximal pole non-union. So in this article, he wrote about a case of a very small proximal pole non-union. Just to conclude what he has written in the chapter, first, the patient has to be advised to quit smoking because smoking apparently has an adverse effect to union. And then we pack as much cancellous bone graft as possible. And of course, we do an arthroscopic assisted technique because a minimally invasive technique will preserve vascularization. This is a no-touch technique. We will not violate the dorsal capsule and we will preserve as much vascularity as possible. And then, because we have a very small proximal pole, we have to do a scapholunate pinning with a K-wire, not a screw, because a screw will take up so much space and will actually destroy the small proximal pole. And then the K-wire is advanced distal to proximal. According to his series, the average time to union is about 2 months. So that's all I'm adding for now, Alam.
Thank you, Maggie. I think it's time to end this first session. Thank you everyone for joining and reading papers, participating. Next up. Please stay tuned with the next regional club. It was our first session today. Next session is scheduled in about 1 month. And thank you, everyone. Jeffrey, Shiab, Alio, Binoy, Alici, and Margaret, and Jean-Baptiste. And good weekend and good afternoon or evening. Bye-bye, everyone.